As healthcare professionals, it's important for us to frame the issue in a way that notices the demand and necessity to focus our attention on developing our care for this patient population. According to the most recent U.S. Census Bureau, the prevalence of Alzheimer's disease has reached a 1 in 9 probability for those over 65. Healthcare spending on Alzheimer's disease also represents one of the most costly investments in our healthcare system today, totaling $226 billion and 1 out of 5 Medicare dollars spent. Additionally, we have an increasing patient population in the coming decades, and without a cure currently, we ought to find ways that we can care for these people well and treat them with the dignity we afford to any other individual in our care. We also notice that elderly persons who are affected by Alzheimer's represent a vulnerable patient population, and I'll go more into that later. In order for us to care for these patients well, as in many other cultures whom we study in order to understand the social context that may affect their decision-making in healthcare and how we approach them, we should do the same for elderly persons who are affected by Alzheimer's. So we look at some current social biases that may affect not only our approach to care, but the patient's relationship to family members, to society in general, and especially the healthcare system. So biases that are associated strictly for just the elderly population, a lot of times they are considered as having less utility and less social worth, sometimes considered non-persons or invisible to society. A lot of the times they also are treated as if they don't know what they're talking about. This is characterized by baby talk and infantilization, that we treat elderly persons as infants as they grow older and lose some of the capabilities and quickness that they once had. Another form of bias that affects Alzheimer's affected persons is the label of cognitive mental illness. Not only is there a heavy amount of stigma associated with mental illness, but especially in the cognitive form, with the cognitive-degenerative diseases such as Alzheimer's and dementia, some characteristics are that they are weak-minded, they are troubled, unable to really grasp concepts, that it is self-induced, that they've done something wrong to acquire this illness. And at the worst, these intersect and often compound to strengthen one another in bias and a denigration of these patients. Consequences of these biases are clear. Elderly abuse is cited as up to 10% of elderly persons facing abuse each year. According to another study, because of the additional vulnerability of elderly persons, it is estimated that only 1 in 14 cases even reach the proper authorities to report. However, the incidence of abuse among patients with dementia is far worse. A couple studies have estimated it is up to 50%. And these abusive tendencies are most prevalent, often with cited reasons of caregiver stress. And this could be a higher amount of time required to care for these patients, a large financial and emotional investment to these people. Sometimes that the caregivers receive aggression from these patients who are struggling with their disease and who may be frustrated in the way they're treated and the freedoms that they're allowed. And also just in the cooperation of the caregiver and recipient, and how well both of them are giving and receiving care. In addition to this higher stress, high abuse rates are justified and strengthened. I use justify in scare quotes, by depreciation of these Alzheimer's patients that include these social stereotypes and biases. When these people are given less social worth and less cognitive worth, it is easy to see how the logic goes down the road of treating these people as less and as not as important. Here's a couple stories coming up from persons who have been diagnosed with Alzheimer's and their stories through that. Richard says, because I was diagnosed at age 48, often people can't believe that someone my age can have this diagnosis. Sometimes when I'm at my best, they try to persuade me my doctors don't know what they're talking about. When I then explain my symptoms, then they act as though I am helpless and should be institutionalized immediately, as if there is no middle ground. They don't realize how insidious this disease is, especially in the early stages. And while I'm still able, I want to articulate and give voice to what it is like to walk in these shoes and let people know that, given this diagnosis, we are capable of contributing to the world around us. Please listen to our voices, individually and collectively. Another story by Chris says, we've mourned the things I can no longer do, and we celebrate the things I can still do. I have good days and bad days just like everyone else. I can no longer work because of this dreaded disease, but I still have feelings just like everyone else. I'm still a wife, a mother, a sister, an aunt, and a friend, just like many other people. And she continues, but this is a silent disease, silent from the standpoint that no one wants to talk about it. They don't want to admit that they know someone with Alzheimer's. Many treat you like you have the plague, and if they acknowledge it, they will somehow get the disease themselves. That is so hard for many of us high-functioning Alzheimer's patients. As clinicians, as diagnostically responsible physicians, we can address bias by maintaining a critical awareness to challenge and address these social biases. Two things that we can practically do is recognize that consistent negative influence against Alzheimer's affected persons can enhance negative social views and negative self-perceptions of these persons. That when they hear these things, not only are they talked down to and this spreads throughout society, but they can also take upon these self-perceptions as negative. This is often seen in baby talk and in infantilization of these elderly persons, that a lot of the times you see a depreciation of these people's intellect or confidence in their own intellect when they're talked down to repeatedly. Additionally, we can actively work against these stereotypes to educate and organize our colleagues and ourselves who are in contact with Alzheimer's affected persons. In clinical care for Alzheimer's patients, we rely heavily on what is usually unpaid and minimally trained family members who give care and provide surrogate decision-making for the Alzheimer's patients to report how the disease is affecting and altering their lifestyle. Just as we as clinicians and healthcare professionals are able to recognize biases amongst ourselves and our colleagues, we also are well positioned to recognize these biases in the reporting from the caregivers to the healthcare team. In doing so, we can recognize in a caregiver report things that may demonstrate a denigration of the worth of the patient, characterized by, as we said earlier, language and statements that may imply that they see them as less or inferior. And this can be a problem with clear implications on how important we think the care for these individuals is. Second, we may recognize language that may unfairly categorize the patient in a way that may promote heavier cognitive restrictions than necessary, that may limit the freedoms of these individuals earlier than they ought to be. And this is especially true for early to mid-stage cognitive decline, when that area of diagnosis for capacity is unclear. The goal of having a useful framework to address social biases is that by influencing caregivers' perception of patients, we may also promote better care for these patients outside of the clinical context. Perhaps through engaging with these caregivers about these biases, about these ways in which we can unwittingly denigrate the human worth and value of these persons. We may also work toward decreasing elderly abuse, especially that within the Alzheimer's patient population. Second, we can have more informed caregivers and families. Just as we can inform our colleagues, we can also inform the people who care for these individuals outside of the clinical context. And in this way, the majority of the care for these individuals can be informed and aware of the biases that may negatively affect their care. Third, most practically, we can get better caregiver reporting data that helps to aid how we diagnose capacity, especially, and the freedoms that we preserve for these individuals. In order to understand the benefit that this awareness can have toward our diagnostics, we must first understand the unique problem that Alzheimer's presents. The progression of this disease does not offer a clearly demarcated line of capacity for decision making, and each case must be addressed individually. Additionally, because the disease is incurable and progressive, we are left without survivor stories that help us to guide future treatment and how we assess incapacity. There's also much contention as to what is counted as having capacity to make decisions, or rather, what substantiates and gives credibility to such reasoning. Where there's a range of mental impairment and a ragged line of what counts as mental impairment, assessments of incapacity in these areas of uncertainty are subject to biases that may unduly influence clinicians and caregivers, that may prematurely demote the agency of the patient. And in doing so, the patient may lose his or her rights to make decisions, for example, to direct and refuse medical treatments that bear significant weight to their own conception of well-being. This effect of bias in uncertain diagnostic categories is common in areas where diagnostic doesn't have a clear biological marker or a clear test to demarcate that line well. And one example is pain diagnostics. The article listed here talked about how when the uncertainty of whether a patient is experiencing pain or not increases, so as uncertainty increases, so does the effect and power of bias. These clinicians and caregivers own bias that is more powerful where that uncertainty is higher. We see this sometimes in dementia rating biases and also caregiver reporting that clinician biases were shown with increased scoring on the dementia scales with the wording they used and didn't use in medical documentation. And this is especially helpful in comparison with how caregivers and the patients themselves rate their own ability to make decisions, to come to conclusions, to give their values and preferences for treatment. This is also a large problem in how caregivers and clinicians rate quality of life for these patients. There have been many studies that have talked about, especially among disability, the disabled person's own concept of well-being, and that matched against someone who is not disabled and who rates their quality of life lower than they themselves rated. And so awareness of these social and personal biases helps to create a buffer for us to be unduly influenced by caregiver and colleague recommendations that may not represent the best interests of the patient. To cite another example of the previous discussion, the higher caregiver burden is associated with rating bias for patient quality of life. In stressful caregiving scenarios, the patient quality of life is rated lower by the caregiver than the patient themselves. And so to have this buffer and an awareness of these biases and burdens that may present that create expectations of the patient that are lower than they ought to be, we are aided to help represent the best interests of the patient above maybe what we hear or expect the patient to be. Practically, this can yield increased and more informed empathic care, and second, a better understanding of a patient's social context and context within the relation of caregivers. In all these categories, we interact with a nearly universal population of elderly persons that represent a vast majority of patients with Alzheimer's, and by nature having a cognitive impairment diagnosis. We have to have cultural competency in this area. It is far more than called for. It's necessary. Further study into this field may help us to kind of elucidate that early to mid-stage criteria for dementia and just shed more light on how we can view these individuals within that context, of course, given by their individual situations. One way we can achieve this is by gathering of patient self-reported data that may aid in substantiating the patient autonomy and best interest claims. One way we envision this happening is through a periodic patient survey whose content is an opportunity for evaluative responses to care, statements of their own personal beliefs and values, and a retrospective analysis of previous responses. That is, patients going back to their previous responses, confirming or changing and attempting to give reason why they've changed in this manner. Our aim is to demonstrate if a consistent projection of the patient's report represents either continuation of the self, even if memory logic seems to be unstable, or if patient can demonstrate a legitimate change of opinion and support with values that at the very least may provide grounds to reject caregiver overrides, that is, either stated in an advance directive or living will, or explicitly, that we can, if we can gather enough values and statements of that nature, we may be able to provide a better defense against caregivers or family members who may wish to override that opinion. This would kind of work in between the standard best interest or substituted judgment standard, where we have substituted judgment maybe in an advance directive or a living will, but can substantiate that more so with being open to receiving the opinion and potential values that the patient themselves state. Regarding the previous conversation we had earlier on infantilization in elderly patients, regarding their confidence and intellectual ability as they are spoken down to constantly. We would like to see if an intentional intellectual and moral engagement with these patients provides a better opportunity for these patients to grow and to speak and articulate their own moral and intellectual values and preferences that we can understand and help care for them better. These would be, in addition to the surveys we've said before, combined with an imperative that caregivers assess their own biases and refrain from negative dejections of the patient, such as the infantilization, the baby talk, the high-pitched voices that we used to talk to babies, but also used to talk to elderly persons. We like to see if that may work to decrease the rate of cognitive decline. At the very least, we will hopefully have a greater and more substantial picture of the patient's will and desires for future care. And second, treat the persons who we are caring for with dignity, that they are persons who have developed these moral values over time. And the more we engage with them over these issues, the more opportunity we have to elicit those values. In closing, by maintaining a critical awareness of current social stereotypes and stigmas, an intentionality to address them in our own personal lives, and a recognition that our personal lives affect and inform the way we practice healthcare, we can position ourselves as advocates and mediators to a vulnerable population, in this case, the elderly patient with Alzheimer's disease. Practically, we can focus on actively engaging the patient in his or her healthcare decision-making and intentionally soliciting the opinion and values of these patients. Gathering these values can better inform caregivers and clinicians when making best interest claims, and with the critical awareness listed above, can protect tendencies to project our own best interest over the values of the patient. The stigmas of mental illness and old age contribute to the demotion of a person's intellectual and decisional capacity, even before any evidence for diminished capacity is found. Thus, especially for patients who are in the early to mid-stage of Alzheimer's disease and dementia, and those who have faced inevitable cognitive decline, healthcare providers must be cautious not to prematurely demote the credibility and the witness of the patient by the actualization of these stigmas. If we are careful, we can identify legitimate changes of opinions and values that inform us how these individuals wish to progress in their medical care. We ought to afford the same rights to guide treatment for an autonomous, competent person, regardless of how their diagnosis reads.